We are going to have our next session of foundation course in palliative care. Today we are going to discuss on dignity conserving practices. We have Miss Seema, Dr. Seema Rao ma'am with us. She is our faculty today. She is the Associate Director, Education and Research, Bangalore Hospice Trust, Karunashraya. And she has completed her postgraduate studies in psychiatry in the year 2000 from 2001 from Rajiv Gandhi University of Health Sciences, Bangalore. With a special interest in geriatric psychiatry, she was associated with organizations working with the destitute elderly, dementia, and chronic mental illness in Mumbai. She has worked as a palliative care consultant in premier institutes like Tata Memorial Hospital, Mumbai, and Kasturba Medical College and Hospital, Manipal. Currently, she is the Associate Director of Karunashraya, a 75-bedded hospice in Bangalore that provides free services for advanced cancer patients. Karunashraya is actively involved in training and research activities in palliative care. I welcome you, ma'am, to your class. Here we have Mr. Balachandran sir with us, Dr. Jayachandran sir with us, and he's our facilitator today. Welcome.
Welcome, madam. Seema, Dr. Seema Rao, Senior Psychiatrist and Consultant in Palliative Care Medicine. We're happy to have you with us today afternoon to give this your valuable talk on the dignity conserving practices in palliative care. Thank you, madam.
Thank you so much. I hope I'm audible to
everyone.
Yeah. So, good afternoon, everybody. And is it possible to have all your videos on, please? I would like to see all your faces. And what is this? Like most of them are doctors or psychologists. How is the? Whom am I talking to?
Ma'am, we have doctors and people from all the sides are here. Not only doctors.
Okay. It's a mixed crowd.
Including common people. We have.
Yeah. Okay. Thank you so much. So let me try and share my screen.
Yes, ma'am, you can.
Yeah. Just give me 1 minute, okay? I hope it is visible now. My screen is visible. Slides?
Yes, ma'am.
Yeah. So what I'm going to talk today is basically a very basic aspect of any human-to-human interaction. Okay, something that we look forward to, whether it is in the healthcare sector or even outside. It's about how do we, it's about dignity conserving care. And today I'll run you through to understand what is the meaning of dignity in healthcare, specific to healthcare. What are the concept of dignity in the terminally ill patients that we see, and to understand the basics of dignity conserving care. So I've divided it into 3 parts and I will be running through this. So when we talk about, most of us are doctors, we are nurses, we are working in the healthcare sector, some of us are counselors, right? So we all know a lot about human body and human mind, right? And we arrive at diagnosis through our understanding of the human body and the human mind. But what does the patient actually want from you in addition to this? It's about, being cared for as a person, not just as a disease, right? So this quote by Peggy Lee, I found very interesting, where, I know a little bit about a lot of things, a bit about biology, a little more about psychology, little gems in theology. But what we actually don't know anything much about is this person, and as we call patient, who's sitting in front of us. If you are able to incorporate that personal aspect into the care, probably we will be more effective as doctors. So before I proceed on to this, what is your understanding of dignity? When I say dignity, what does it mean to all of you? You can put it in the chat box, or you can unmute yourself and talk to me. Sorry. Anybody? This won't go ahead if you don't answer. So I can see Sandhya Paul, Atsang in Chen on screen. I hope I pronounced your name correctly. So one of you can please tell me, what do you understand by dignity? Respect, okay. Protecting modesty, self-respect. Excellent. Yeah. So basically, most of you have used that word respect, right? Yeah.
Yeah.
Not able to get rid of the chat that has popped up actually. Okay. Yeah. Yeah. So when we look at dignity, the concept of dignity, I think a lot of literature speaks about dignity, whether it is philosophy, whether it is politics, whether it is law or ethics. The concept of dignity is enshrined in our constitution, isn't it? The right to live with dignity is a fundamental right of every citizen. So the definition of dignity varies or changes depending on the lens that we are seeing. Is it from a philosophical aspect we are talking about dignity? Is it from the political aspect or from the law or the healthcare aspect? When we look at concept of dignity in the terminally in healthcare, we talk about quality or state of being worthy, honored, or esteemed. That is a definition given by Chachina et al. There is another definition in 2016 by Barclay, which says it is the ability to live in accordance with one's standards and values. And Levinson in 2007 spoke about it's about how people feel when they are receiving care from the healthcare providers. So as you can see, there have been very different definitions of dignity. So basically, it's very complex, ambiguous, and which has a lot of definitions. The concept itself is very difficult to define. But generally, when you look at it, we look at two concepts in dignity. One, what we call as basic dignity. That is what we talk about in philosophy, we talk about in law, we talk about in politics. It's about that all human beings are worthy, have an intrinsic worth, and or what we call as dignity. They are worthy of respect. And this dignity cannot be taken away, nor can it be enhanced. It is there because you are a human being. And actually in Hindu philosophy, if you see, any matter, living or non-living, is worthy of some respect. That's why we worship stone, we worship trees, isn't it? That's some inherent value that is attached. That is what we call as basic dignity. What we are talking when we talk about dignity conserving care is about the personal dignity that we see. Okay, so what are the components of this personal dignity? It is about social dignity, how I am being treated by the healthcare system, what decisions I am allowed to take, what we call as autonomy. And as all of you rightly put in the chat box, it is about dignity of self. It's about my self-respect, how I look at myself as a patient. Okay, and it also what I call dignity in relation, how the society, the healthcare system treats me. Right? All these are components of personal dignity. And it is this personal dignity that gets affected when you have a disease or when you have to go to meet a doctor. Okay, it's very individualistic, and it's tied to your social circumstances, and it's a measurable concept. So basic dignity is not what we are talking about in healthcare. We are talking about the personal dignity aspect of it when we talk about dignity therapy and dignity conserving care. I hope that is clear to all of you. Yeah. So I'm just to highlight the patient's example. This is one of our patients who had come to us. He's around 70 years old, retired school principal, very strict, with a very dignified, as we call it, demeanor, very disciplined and very autocratic. He takes all decisions in this house. He's been living alone for the last 3 years because he lost his wife quite some time back. He has a very set routine every day. Early morning, he gets up, he goes for a walk, does some, and he has a group of friends with whom he goes for a walk with, and he comes back, has a bath, and starts his puja. Staunch believer in God, and his rituals mean a lot to him. And once after that, he goes to his previous school for some time as a volunteer and takes extra classes for those children who are very weak in their studies. And the family, of course, are staying away. Daughter is abroad. Son is staying in a different town who visits him on weekends. And he was recently diagnosed with metastatic lung cancer. And is quite breathless and he has continuous cough. Accompanied by his son, he goes to visit in the hospital, he goes to visit the doctor. So let's see what happens to him when he enters into the hospital. Okay, so first of all, it's a very crowded waiting room that he gets into, and he's coughing continuously. And because he's coughing, and nobody is aware of what disease he has, the other patients are all, they show that little bit of disgust when they see him and they move over a little bit. And in the examination room, the young lady intern comes and asks him to remove his shirt. As he's lying there and she's about to auscultate him, when her friends come into that room and they talk about the upcoming exams that they are supposed to be having. And suddenly this gentleman coughs and she tells him rudely, turn your face that side and cover your mouth. She tells him in a very rude manner. And after she finishes examining him, he follows her. She meets the senior doctor and she tells him, sir, this is a case of CA lung. Without taking his name or anything, she explains it to him. So the doctor examines, prescribes medication, discusses with his son, who's there with him. And Amit asks his son, once they come out of the doctor's room, Amit asks his son about what is happening to him. So the son tells him, you take your medicines, doctor has given you, you'll be fine. Don't bother about anything. Don't take any stress. Okay. And as the son goes to get the car, he's standing near the the gate, when the security guard shouts at him for blocking the car. And once he reaches home, his son tells him that, Dad, you just move in with me. You will not be able to manage alone. Amit is upset. He feels lost and he's furious and he feels he's a burden on everyone. So can you tell me where all in this scenario is Amit's dignity getting hurt? Can you identify? Put it up in the chat if you want.
Yes.
Or you can unmute. The entire episode, Harpit Nair, yes. But can you tell me specific areas where you feel that probably this individual is feeling little devalued?
Yes. So when he's at the table, I mean, examination table, there are certain protocols of not talking about the patient's medical history in front of the patient, and they're breaking that protocol. They're doing that as well. And then the tone in which the people are talking to him, and at the gate when he's chided by someone as lowly as a watchman. So basically everything is robbing him of his dignity. A man who was the principal of a school and has been the epitome of dignity is now in a situation where suddenly everything is just, the tables have just turned.
Yes. And
I think it's also about disrespecting his choices, just giving him the medications, not explaining what his illness is about.
I missed out. Our hospice is next to a airport. So the fighter jet, I can, that sound sort of drowns out everything else. So somebody else was saying something, right?
Yes, ma'am. Punni ma'am,
Yeah.
please, can you speak up again?
Yeah, it's about not explaining his illness and not respecting his choices. By just routinely saying you should just take medicines and you'll be okay,
Yes.
without even explaining what his illness is about and what his choices could be.
Yes.
Um,
Absolutely. So thank you, Harpreet and Puni. That was, I mean, you were right, bang on the spot actually to say that there are, and is this a common occurrence in most of our hospitals? Does this happen?
I think it depends on the physician. Some do explain, and a lot of times I think families think that they're trying to protect the patient and just not disclosing
Yeah.
the actual diagnosis. I think it does vary with physicians.
Yeah. So more or less, so there are multiple areas, in fact, the very fact of how the other patients move away when he's coughing, right? And the fact that some choices are taken away. All these are places where, where a person's dignity gets affected. And for Amit himself, who looks upon himself as a doctor, as a school principal, the very fact that he's breathless, not able to do his routine day-to-day work also is very humiliating, isn't it? Having to depend on others, right? So, yeah. So I guess these are all issues where dignity gets eroded at every phase or every part of the patient's journey. So when we look at things, when we actually classify what are all the factors that impact the dignity or rob an individual of a dignity, it could be factors that are dependent on the illness. Okay, it's about how the illness creates the impairment within that individual, cognitive as well as physical, the symptoms, etc. It could be certain factors that is dependent on the individual's psychological as well as the individual spiritual landscape, the very fact that he is not able to do his day-to-day routine and all that. And also some of the factors are dependent on the social context. Okay, so so these are the things that can impact an individual's dignity in the healthcare sector. So we'll look at each of these concepts one by one. So when we look at in Mr. Amit's case, when we talk about factors that are mediated by the illness, the first thing is the cough and the breathlessness is disturbing him too much. It could create a lot of anxiety because of the cough and the questions that will this disease, what I'm having, be cured? Am I going to die? And the fact that he may not be able to do his day-to-day activities like he was doing before. And also cognitive impairments, which most of the diseases or advanced cancer brings in, inability to remember and manage their day-to-day life. All these can impact the dignity in the individual. Actually, the diagnosis of a disease is a journey from being a person to being a patient, right? And the individual is lost in the process. If we have a 26-year-old patient who's thoroughly emaciated, admitted to our hospice with advanced metastatic lung cancer, and he's so emaciated, and what he carries around is the pictures or the photos of what he was before, right? And a very handsome young man, right? So when he looks at himself now and then what he was before, that sort of, the whole person is lost because of the disease. His interests, his hobbies, is not able to do anything at this point in his life, isn't it? So it's all a journey to patienthood. That's what happens when a disease happens. So when we look at this illness related concerns, a patient who's vomiting continuously, right? How do we feel if we sort of vomit in front of others? What is the emotions that we might feel? Yeah, ashamed of ourselves, feel guilty about doing it, right? So here you have a patient who's a lot of physical distress, who's moaning in pain in front of others, or even this gentleman, Mr. Amit, who's coughing in front of others. The physical distress erodes one's dignity, the psychological distress, the anxiety about what is going to happen, the fear of death, the medical uncertainty that the disease brings. All this robs one of their dignity rather. And of course, the level of loss of independence is another main thing, being a burden on others. So it's very important that as we see this individual in our day-to-day practice, either as counselors or as doctors, we need to identify which of this is causing the person more distress. Okay, being mindful of all these factors, asking them about it, and which of these factors are causing the distress in that individual is one way of providing what we call as dignity conserving care. And if you can see here, there are specific questions available to explore each of these distress, and also to, you know, what you can do to alleviate that distress that it brings. Right? So is this clear to everyone so far? Before we move on to the next segment? Yeah. The second aspect of, yeah. Any doubts?
No, ma'am.
Okay.
Please carry on.
Yeah. So the second aspect is there are some factors that dependent on the individual. See, when a patient's illness is progressing, activities coming down, they are more and more confined to the house. This gentleman who used to go for the morning walks, his morning rituals of, you know, praying, highly independent individual now has to hand over control to somebody else. Okay, the thoughts are that illness has taken away all of my respect. How do I find the strength to go on? I will need to make the best. How are people going to remember me? I'm no longer the person that I used to be. You know, not being able to do the job. There are a lot of these thoughts that happen within the psychological mind frame of that particular individual. So these also can sort of affect dignity. So the one section of what we call is dignity conserving repertoire. What are the things that we need to do to help patients conserve their dignity? Primary one is continuity of self, as we call it. Okay, finding out what were the things that were important to them before the disease happened. Okay, and what are the things currently that the disease does not affect at all. For example, a mother whose main role has been cooking and looking after her children probably is unable to do this because of the disease. So has lost that connect to herself, right? Because of the disease. So probably talking to her, finding out what is important to her and helping her to control what we call as role preservation. Continue the activities to a limited extent. Maybe she's not able to do the whole cooking for the house, but she can sit and cut vegetables, maintain as much normalcy as possible. Okay, and you know, find out what are the things that, you know, she is very proud of in the life, finding out that within that individual and giving some sense of control for this individual, like making them partners in the decision making process, the autonomy that they feel that they are able to take the decisions for themselves. These are all things that can be done to preserve the dignity. The other aspect what we look at is how are people going to remember me when I'm gone? What we call as generativity or legacy, creating these documents of legacy. What do they want to tell their loved ones? You know, how do they want them to remember? Or so these are things that we can talk about during the therapy sessions that we have in. Pardon, you can't hear me?
Yes, ma'am. It was some network issues or something else.
Is it
Some
okay
network.
now?
Yes, ma'am.
Yeah, sorry. So these are things that we can sort of focus on during our conversations in order to sort of, you know, help patients cope with what the distress that they have. So how do we help them role preservation, continuity of self, maintenance of pride. How do we help them do it? Okay, there are some things like what we can teach them. One is about living in the moment. Okay, focusing most of the time, patients tend to plan ahead and think about what is going to plan way ahead. So bringing that focus from past or from the future into the present. Okay, look at what is possible today. Today, your pain is under good control. What is it that we can do to keep you as productive as possible for today? We don't know about tomorrow. Tomorrow, the pain may go beyond control. They may be bedbound, they may not be able to do anything. But early in the morning, to prioritize, to see what can be done for the particular day today when the symptoms are under control. So teaching them to live in the moment, maintaining normalcy as much as possible. Much of the time, what happens is once an individual falls sick, the control is taken over by a lot of the family members. One of the commonest thing that we'll tell is you go and take rest. Don't strain yourself. Don't stress out. We will take care of all the cooking, or we'll do everything. You please take rest. Isn't that the common refrain? So what happens? The patients gets isolated from the normal day-to-day activities. So this is something that we need to avoid. So encourage families and encourage patients to maintain normalcy as much as possible. And of course, some of the and seeking spiritual comfort, maintaining connectedness. What is spirituality? Anyone?
It's more of believing in God or some supernatural, something divine.
Okay, a part of it, yes. Mainly spirituality, when we defined in palliative care terms, is the ability to find meaning and purpose in life and remaining connected to oneself, connected to your values, beliefs, environment, and also to the sacred or the transcendent. So what you defined connection to God or sacred or transcendent is a part of spirituality. So helping patients to maintain connectedness with themselves, what they were before the disease struck. Okay. Also maintaining connectedness with others around them, and meaning making. These are all techniques that you can use to enhance dignity. So if you can see, when we talk about dignity, it's not only about the psychological aspect, isn't it? There is the physical aspect of dignity, there is the psychological aspect to it, there is a practical aspect, there is a spiritual. So we need to find where is this individual suffering a loss of dignity in, and to enhance that aspect of it. Okay. So, and then the third aspect, as I said, one is about the disease, one is the psycho-spiritual landscape of that individual. The third, the society. Okay, how people around treat this particular individual can also have an impact on the dignity of that individual. The fear of being a burden, not getting support from family and friends, fear of what is going to happen to the loved ones, unfinished businesses, about settling down, that can, and invasion of privacy can erode the dignity. And the one of the most significant aspect of dignity comes from what we call as the care tenor. How does the healthcare system treat this particular individual? What they say is, if we devalue the individual will devalue themselves, the family will devalue this person. But if the healthcare system is able to incorporate and treat every patient with dignity, and then patients also look at themselves, the relatives look at the patient as someone valuable. So a lot depends upon how we treat our patients. So one of the important things in this social dignity inventory, as it is called, is privacy. Okay, recently I saw in the chat box, private hospitals are a little more, careful about what dignity is, right? I think that was mentioned in the chat, somebody had written. So I had a recent experience when I went to one of the corporate hospitals in Bangalore. So I was taken in for an echocardiogram, and I was lying on the table for the echo right next to a door, and the nurse, there were some 4 or 5 nurse practitioners who were moving in and out of that room, opening the door, closing the door, opening the door, closing the door. And here I was lying down with the leads attached to my chest, and it was a very distressing situation until I had to sit up and tell them, that this was in a private hospital. I really felt very assaulted. I felt my dignity was assaulted, because here you were with the leads attached to you, waiting for the echo to be done, and 3 or 4 nurses were walking in and out of that room. So your privacy also is invaded, isn't it there? I myself, when I'm perfectly normal, felt that way. Imagine what the patient would feel. So it's not only the healthcare system. Sometimes I recently had this again in the previous hospital I was working in. I had a 17-year-old girl with a osteosarcoma, a tumor of the bone. And I had to auscultate to see whether her lungs were clear. I had to keep the step and auscultate. So I asked her parents, can you please lift her and make her sit up so that I can check her lungs? And she was wearing the hospital gown, and the father and mother made her stand. It was a general ward. There were a lot of people around. They just, before I could ask the nurse to bring the screen for the testing, they just made her stand, and her robe was open completely in the back. Would this situation have happened anywhere else? What would the parents have done? They would have insisted that the girl cover herself up appropriately before stepping out, isn't it? But in the hospital situation, even the parents don't look at her as an individual, right? Their own view of the daughter had changed, right? So privacy boundaries are extremely important. Asking permission, whether to examine the patient, draping to safeguard and respect the privacy of the individual is extremely important. The other second aspect is social support. Much of the time we see patients living in a joint family, and we assume that they have enough support systems because there is people who are doing things. It's very important to ask them whether they feel supported. And as I mentioned, one of the important aspects is how we treat our patient, the care tenor of the healthcare provider. We have to treat every patient as worthy of honor, esteem, and respect. A patient, even a delirious patient, a patient who is mentally ill, gets sort of neglected in the normal course of events. And these are things that we have to be mindful about. And there are sometimes some patients who feel they are more of a burden on others, and I mentioned aftermath cancers. So these are things that we need to look into, address, in order to patients to experience an enhanced sense of dignity. So far, any questions from anyone? No questions? So how do you think we can assess dignity? Anyone who's working in palliative care or whatever? Do you know of any instruments or tools that can be used to assess dignity? You can put it up in the chat.
I think 3 important things which we need to keep in mind is, one is being sensitive to the patient, and also respecting and then taking their permission. I think these 3 are important.
Excellent. Okay, Gautami has written asking the patient about their needs and how it's taken care of. Yeah. Now, these are what I've said is so many things are there, isn't it? How are you going to systematically address or find out which is the source of concern? So there is an instrument that has been developed. It's called as the patient dignity inventory. Okay. So now I have told multiple things, something related to the disease, certain things related to the individual, and some related to the social context, isn't it? So this patient dignity inventory helps you to understand how the patient in your care is coping. So there are about 25 questions which covers all the domains that I have so far mentioned. Okay. And there is varying severity. Okay. Less, minimal impairment, severe impairment, varying from 1 to 5. So this is a self-reporting questionnaire. Patients can be asked to rate themselves on this. Okay. And look, see, it's not necessary that one patient will feel all the 25 things, isn't it? Some things are more important to some things aren't, right? So depending on the individual, they would mark what has been impacted mostly by this disease, and that gives you an understanding of this individual in front of you. And looking at this, then you can address the specific concerns of that individual. So this is a very easy reporting tool which has got very easy for the patient to complete also, and it will give you an idea of what the patient is going through. Now suppose it's about worrying about my future, item number 8, where there is severe impairment or has been severely impacted, then probably we could start conversation with the patient and the family about what is the future planning that he or she wants to do for the family. What are they anticipating, probably based on that. If they are feeling uncertain about the illness and the treatment, probably information, giving them the right information in the right manner would be important. If there are unfinished, like item number 16, things unsaid or incomplete, unfinished businesses that is troubling them, then probably you could initiate this talk and discussion with the family. If so you could explore each of these concerns and address them individually depending upon what concerns which patient. So this is a very good tool for using to assess dignity. So now, how do we ensure that patients feel supported, or the dignity is enhanced in patients whom we are looking after? So a lot depends upon us. So there are two techniques that we normally use. One is what we call as dignity conserving care. The second is dignity therapy. Dignity therapy is a psychotherapeutic intervention. Probably it's a more specialist approach. But dignity conserving care for an healthcare provider should be like breathing, right? Do we pay attention to our breath? It comes automatically to us, isn't it? Right? So this dignity conserving care should come automatically to every healthcare provider. We should be mindful of this. It's a culture of care and a way of relating and treating the patient, which each one of us have to learn. It's about treating patients with kindness, humanity, and respect. And like there is an ABCD to it, right? It's called the attitude. We have to look at what attitudes we carry in, as we meet our patients. How is our behavior towards them? It's about building compassion within us, and it's about communicating in a manner which acknowledges the personhood of that individual, not the patienthood, but the personhood of that individual. So it's about you just A, B, C, and D. So one of the things that I commonly hear in palliative care is, or in a palliative care setups is, one, the patient is anyway going to die. What is the point of doing anything, right? Recently, just today, I had we were discussing about a patient who had lung cancer and who had a massive pleural effusion. Okay, that is the collection of water outside the lungs. Okay, normally what is done is a tube is put so that that collection gets drained completely and the patient is able to breathe easily. But in one of the hospitals, they removed the water twice, but they have not put in the tube so that, that what we call as an ICD. So again, the attitude that is normally carried is this patient has advanced metastatic untreatable lung cancer. What is the point? Anyway, nothing can be done. So if we approach with that attitude, then quality of life ceases to matter, isn't it? We sort of, we are not doing the adequate interventions. We are not doing anything to make the life easier. So we have to be very mindful about what attitude we carry. There was this patient, we sometimes label caregivers as very problematic, difficult, always complaining, and she complains of pain only when she sees a doctor. And we carry our assumptions, our worldview into our therapeutic conversations that we have with the patients. We carry that with us. So we have to be mindful that we set aside whatever preconceived assumptions that we have before we approach a patient. Any patient, whether in palliative care or otherwise, we have to be very mindful of it. What is attitude? Attitude is an enduring, learned predisposition to behave in a consistent way towards a given class of objects or people. Not like how they actually are, but how we see them to be. So this attitude of us is something that we have to be very mindful about, and we should be very non-judgmental when we approach each of our patients. And remember, the attitude that you carry can be contagious, and even the family members also will mimic your attitude towards the patient. So we have to be very mindful of this. So when we look at our attitude, one thing that we look at is, being empathetic. How would I be feeling in this patient situation or in this caregiver situation? What is making me think this in this manner? Okay, is my assumption correct or not? Is there some way that I should change my thoughts about this individual? And how is that attitude affecting the patients? Okay, and is my fear, anxiety, etc. influencing the my interaction with this particular patient? So, these are the questions that you have to ask yourself when you address a patient or when you go near the patient. Being mindful of it is extremely important. So, what in dignity conserving care, to develop a more non-judgmental attitude, what we advise is that whenever you see a patient, it is better to take some time off for reflecting of how or when you see a difficult patient, when you're having some difficulty with an individual, a caregiver or a patient, it's important that you reflect about it with your colleagues to see what has been your attitude and how your attitude is influencing the interaction with that particular patient. So one of the best things to do is to have discussions with your colleagues who will be able to identify these things and help you develop a more non-judgmental attitude. The second aspect of B is behavior. Whenever you are with the patient, be sure that you mirror respect towards the patient. You look at that patient as an individual. Sometimes doing small things like, helping the patient down from the examination table, holding their hand if they are, limping, leading to them to the door, calling them by their names, adjusting a pillow or a bed sheet to make them comfortable, taking permission before you examine the patients. These are all methods that you can use to make the patient know that they are valued, right? So every contact with the patient, you should look at it as a clinical intervention. A simple example, before you do a surgical procedure, what do? I'm sure most of you have seen in movies, etc., isn't it? What do? You'll scrub yourself, you will disinfect that area, right? So there are a lot of steps that you do before a surgical intervention. So even your interaction with the patient that you have is also a clinical intervention, and it should be predicated by respect, kindness, and there are certain things that you need to follow, like asking the patient's permission before doing a physical examination, asking permission to include students. You have observers coming with you, you ask the permission whether it's okay to bring them along. If the patient says no, don't take them along. If they say yes, then take their permission before you do that, and set the patient at ease and communicate in a manner that you tell them that you appreciate what they are going through. And these are things that, these are simple things that you can do to enhance that dignity that the patient feels. And most of all, one of the most important aspects that you need to do is you need to show compassion. So I have put 4 things here, isn't it? Pity, sympathy, empathy, and compassion. Can anyone explain to me what these are? What is pity? What is sympathy? What is empathy? And what is compassion? Anyone? Pity is just feeling sorry, okay? Sympathy. Feeling sad for them, okay? Sympathy is feeling sad for them. Empathy.
It's feeling with them.
Feeling with
With
them.
them. Yeah.
Okay. Compassion. What's compassion?
Concern, love. Concern, love for them.
Love for them, okay.
We express our feelings through action.
Expressing feelings through action. Okay, okay. So let's see, I'll just explain 2 things. It's about, one is about understanding of the problem. One aspect of all this is about understanding, the ability to understand what the other person is going through, and the second aspect is the way you connect with them, right? These are 2 things that you have to look at. When we look at pity, you understand the other person's problem, okay? One who is worse off, and as someone rightly said, you feel sorry for someone. Oh no, such a shame this happened. Okay, this is what pity is. Okay, connection is not there. It is just the understanding of the problem that is there. And you perceive yourself to be on a higher plane, and you're looking down and feeling sorry for the other person. Okay, so that is pity. Okay, probably something that is not generally needed in palliative care. When we look at sympathy, there is understanding of the problem and there is a little bit of connection. Okay, so I am sorry and sad that you are experiencing this. So the understanding of the problem is there, and there is, while in pity there is no connection, here there is some amount of connection, but still you are sympathizing. That's it. When you talk about empathy, it is you are able to understand what the other person's problem is, and not only that, your connection is also very strong. You are putting yourself in the other person's shoes. Okay, so the understanding and connection is high in empathy. I can imagine exactly what you are going through, right? That is empathy. Compassion is one step ahead. It is empathy plus action. Okay, so not only are you understanding, you're connected with the problem, but you are taking an action to reduce the suffering of someone, right? So I know what it is like, and I want to help you reduce the suffering for you, right? So in pity, understanding is there, but no connection. In sympathy, understanding is there, but less connection. In empathy, understanding and connection. You feel exactly what the other person is going through. In compassion, it is empathy plus action. Is that clear? So how do you develop compassion? Is it normal, or can you develop compassion? Amalraj, yeah, right. All denote our feelings towards the suffering of a fellow person, only graded as per positivity. I would say only graded as per the extent of connection that you experience with the other person, right? Yeah. So do you think compassion is inborn, or you can learn to be more compassionate? Anyone? Okay, lot of developing compassion through practice. You can learn. Some people are more compassionate. However, it can be developed. Excellent. Harpreet, how can we develop compassion? Any idea? What can we do to develop compassion?
Compassionate care.
How do you learn to be more compassionate?
Understanding the feeling of the person.
Okay.
Understanding and understanding his needs, requirements, feelings, and then accordingly behave.
Okay. Accordingly behave. Okay. Who's speaking?
Jayachandran from Palim, India.
Oh, okay. Oh, okay. Because I can't see the okay. Thank you. Thank you so much. Yeah. So I feel this is also trait in any person by being more empathetic, treat other person as human being. Okay, fine. So first of all, to develop compassion, we should know what we are feeling. It's very important to get in touch with one's own feelings. Okay. And the other thing is to learn through observation, reading stories, observe movies, theaters, okay, discussions of narratives. That is where narrative storytelling comes in, isn't it? We just had, Palim India just had a session on storytelling. These narratives help you to develop compassion, sometimes through arts, okay, and personal stories that accompany illnesses. Listening to that, we start understanding how a person with an illness, what they are feeling, what they are going through, and then we identify with some of the things the other people are going through. So that's how you can develop, yes, compassion within you. And cultivating a habit of caring, somebody has written, absolutely. So doing small things in your regular day-to-day life, that sort of, and it's very addictive. Once you start doing it for others, the gratification that you get, okay, so makes you more and more compassionate with time. So it's a very rewarding experience for the one who is receiving as well as for the one who is giving, right? So these are all ways when you can sort of, cultivate it within you. And the fourth of ABCD is dialogue. Dialogue is the communication that you have with the patient. What, as a healthcare provider, it's a very important element of dignity conserving care. So when we look at, we say we have to acknowledge the personhood. How do we acknowledge personhood? Anyone? Any techniques that you use in your interaction with patient where you think of acknowledging personhood? Simple conversations that you have. Anyone?
respecting.
How do you show respect?
By in our behavior, we can respect a person, no? By verbal and non-verbal behavior.
Absolutely. Yes. Agree, sir. Thank you so much for that. Addressing by their names, that's the answer I was waiting for. Yes. Asking for and considering their opinion and feelings. Absolutely. So one of the primary things is, when I go, I make it a point to call the patient by the name. And what do you think the expression normally is? When you call a patient by the name, yeah? So generally, sort of, they become very engaged. Rapport building becomes easier when you call them by the name, and starting off the conversation, yes, glowing face, yes. Acknowledging their individuality rather than their illness. Absolutely. So rather than going directly and asking how is the pain today, asking about what they did, I normally start off with the 1 to 2 minutes of non-threatening, non-illness related talk. Who came to see you yesterday? The weather is very good today, isn't it? Okay. You're starting off with something very non-illness related and then moving on to the illness. It shows them that we respect them as the person that they are, and then we look up that disease is just a part of what the person is, right? So that's how I negotiate this. Each one of us will have to find our own comfortable ways of acknowledging personhood. The other thing that I do is I sort of make a note of the names of all the family members. And then I go and ask, I don't say, did you speak to your daughter? I ask, did you speak to the daughter's name, whatever it is, So then they also feel validated. Doctor knows more than, knows my daughter's name also. And that sort of validates them and shows that I'm respecting them as a person. Okay. And the second aspect is about compassionate communication. How do you communicate in a compassionate manner? How do you do it? What are the things that probably you would focus on when you're talking to an patient, an individual, that makes for part of compassionate communication?
You can start with what they are worried about to begin with.
Yeah. What matters to them, asking them, right? Before we set off on our agenda. Okay. Anything else? Chat में something, tone, gesture, touch, absolutely. Attentive listening, absolutely. So I'm not going there because most of you are on the path to it about compassionate communication. Sometimes silence, concern, touch, non-verbal gestures, allowing patients to express their pain, maybe cry in front of you, just taking a chair and sitting in front of the patient when you're talking to them, telling them, okay, I have enough time to give you, right? So these are all things that you can do to express your concern and compassion towards the patient. And then there are always psychotherapeutic techniques like dignity therapy, meaning-centered therapy, life review, which we will be speaking in the next session probably. And why are we speaking so much of about dignity? So it's an important goal when we talk about palliative care. And when patients experience a fractured sense of dignity, there is an increased desire for death, loss of will to live, there is depression, hopelessness, and quality of life goes down. So this was a study that was done in between 1998 and 2019 in Oregon. They passed this Death with Dignity Act. Okay, so 188 people died using the medication under this act. Okay, 75%, I mean, this is the demography of those who requested death and died. One of the main concerns for request for death was that it's about loss of autonomy, loss of dignity, and decreased ability to participate in enjoyable activities. These were the three major concerns. And if you subsume this loss of autonomy and combine the loss of dignity, majority of them asked for death because they experienced a sense of loss of dignity. That is why it is very important for us to focus on this aspect so that patients' quality of life improves. And how do we do it? It's what is this dignity conserving care? It is restoring the personhood of that individual. So there are 25 concerns, as you have seen in that patient dignity inventory, right? Which any of these can be eroded. And when they come to us in distress, many of these aspects may not be looked into. And as palliative care providers, when we look after the physical symptoms, it's extremely important that we restore in whatever way we can the small aspects like autonomy, sense of burden, role preservation, managing the symptom distress. All that we do is a process of restoring this dignity for our patients. And one of the major aspect in all this is the way we treat our patients. Care tenor takes leaps and bounds, it is what sort of, we have to be very mindful about. So these are Dignity Therapy by Harvey Max Chochinov is a good book, Final Words for Final Days. If anybody is interested in reading further. Another lovely book that I would recommend is The Diving Bell and the Butterfly. This is the story of a 45-year-old editor of this Elle magazine, fashion magazine in France. This gentleman had a massive stroke, and post-stroke, he was able to move only one eyelid. Okay, and what we call, he was in a locked-in syndrome, as we call it. And what would you expect the course of this individual's life would have been? Can you take a guess? He's not able to move, totally paralyzed, only able to bat an eyelid. In the normal course, what would have happened to this gentleman? Anyone?
He would have been bedridden, desire for death.
Yes. Okay, right? He would be just a vegetable lying somewhere, isn't it? But fortunately for this gentleman, his occupational therapist speech therapist realized that he could communicate by blinking of the eye. And she started communicating with him in that manner. Over a course of time, they developed a code, where she would show him, he was a writer, editor of a magazine, right? She would show him words and he would blink once, twice, or thrice, depending on what, and pick out words, alphabets and words. In that manner, okay, this gentleman, over a period of, I think, maybe 3 years, if I'm not mistaken, wrote this book, The Diving Bell and the Butterfly. It talks about such a rich life within that paralyzed body, the mental cognitive activity that went behind. For all the rest of the world, he was a paralyzed man with only movement of one eyelid. But the story is full of humor. It's a lovely book. The diving bell is his body, which is rigid. The butterfly is his mind, his spirit, which was soaring all over. And it talks about how healthcare providers were very uncomfortable in his presence. He was able to perceive the discomfort also. And he writes about it in this book. It's a lovely book. It's a movie also and worth reading. And after this book was published, he died about 3 days later after publishing this book. So the dignity conserving care is about whatever an individual's state of health. Okay, that individual, there is an intrinsic worth value in that life. And it is for us as healthcare providers to respect and value that individual in whatever form, whatever way they come to us. And that should come as naturally as breathing to all of us. And that's what dignity therapy, conserving care is all about. I'm open to any questions.
What is expected as an outcome of the dignity therapy? Quality of life?
Pardon?
What is expected as an outcome of the dignity therapy?
Okay, so outcome, this was dignity conserving care, which I'm talking about. Dignity therapy is little different, which we will, I think I have next session sometime in first week of April on that. So the outcomes they have looked at is demoralization, anxiety and depression, and improvements in the dignity inventory. Primarily it's more of a psychological outcomes that they have looked up, and that is one of the disadvantages is that you cannot measure, right? This is such a multivalent concept that exact measurement may not be feasible here.
Will it improve quality of life?
Will it improve?
Quality of
Quality
life?
of life, yes. There are studies that have shown both, but definitely on an experiential aspect of it. Qualitatively, patients as well as caregivers have reported a lot of improvement. Measurably, statistically significant, it is very, what do you call it, ambivalent there. Some studies, some RCTs have shown, some RCTs have not shown. So that portion is quite ambivalent. But qualitative experience, yes, that's the thing.
Can it be therapeutic also?
Yes. Not conserving care, dignity therapy. I'll discuss about that, next is yeah.
Anyone else have any doubts? You can unmute yourself and speak, or either you could put it in the chat box, please.
Any questions, any comments?
Can we make it a culture of care?
Yes, it has to be a culture of care. That is exactly what I say. It should come naturally as breathing to all of us, So that's something that I do mostly with the nursing staff here. It becomes extremely important, especially when we come across unconscious patients, right? Are there any nurses in the group?
Yes, ma'am.
Okay, so care of the unconscious patient. Can somebody tell me how do they approach an unconscious patient and how do they manage them? Any of the nurses?
Person is conscious inside.
So generally what happens is when you give a sponge bath, for example, you sort of tell a conscious patient what you're going to do, yes or no? That I'm going to, give you a bath. You will explain, isn't it? Yes. Okay, Farah Kazi has written yes. Do you do that to an unconscious patient? A patient who's comatose or who's unconscious, do you do that to them? They are treated more like a body, isn't it? Yeah. So exactly. So what we sort of try to do here is to even if a patient is unconscious, is not aware of what is happening, we don't know what cognitive process and how much of perception is there inside. They may not be able to tell you that they are feeling it, isn't it? And they may not be, their eyes are closed, so they may not be able to see what you're doing. So it's extremely important to tell them that now I'm going to give you a bath. I'll be wiping your hand, and constantly keep that commentary on about what you're doing to the body, so that the person understands. If he is understanding, he understands what is happening to them. So that is one of the basic things we teach. The second thing is when we auscultate, right? The stethoscope we keep on the chest or whatever, or the abdomen, when you're listening to bowel sounds, you keep it directly on the skin of the patient. Sometimes the stent can be very cold. So warming that stent before keep showing the person that, even the slightest of discomfort, you don't want to give to the patient when you're in your interactions. It could be physical or otherwise. So, and when you are feeding the patient who's unconscious through a rice tube, telling them that you're going to give a feed. And what is the feed that you are giving? Is it a soup? It's a kanji vellam? What is it that you are going to give? Telling them that and giving it. These are all things that has to come into the day-to-day practice in order to validate that individual's existence. They may be immobile, not able to communicate with you, but it is important that we continue to respect them as we would respect any other person, individual. I think if there are no questions, then we can.
If there is no more questions, we could wind up the session. If anyone have anything to ask, please, we have time.
Ask or to share even.
Yes.
Good interaction, good message, and everyone can take it home, the message of the dignity of care in their culture of care, not only at the hospital, at the home also. Dignity is really valuable everywhere walk of life. Give dignity and take it.
Yes, absolutely. Even in our interpersonal interactions between colleagues also.
Yeah.
Thank you, ma'am. I
you so
think
much.
there is no more questions from the side of the participants. I think we can wind up here. Thank you, ma'am. Thank you for your time and presence and this wonderful presentation you had today. Looking forward to have many sessions again with you. Thank you so much. And thank you, Jayendran sir, for being with us today. Thank you all. We'll see you on the next class. I am sharing the feedback link with you. Please go through it and please fill it up.